This is Kojo Hamilton describing occipital cervical fusion tips and tricks. I'm a professor of neurological surgery at University of Pittsburgh School of Medicine and University of Pittsburgh Medical Center. The first few things that we need to discuss is our preoperative planning, really to be very well aware of your basic anatomy, bony anatomy, neuroanatomy, as well as the vascular abnormalities in this area. The first things that I want to do is also have a team approach to this with a preoperative team discussion. One, neuromonitoring, what kind of neuromonitoring you're using. Typically will be both somatosensory evoked potentials and also motor evoked, transcranial motor evoked potentials. You want to discuss your blood pressure goals with your anesthesia team and also expected blood loss, particularly if there's concern for any dissection or potentially a blind transgression of any vasculature. We're also worried about instrumentation. We also want to discuss positioning. Initially, most of these cases are done prone. There's on rare occasions, such as severe spondy, where you may have to position somebody in a sitting position. However, over 98% of these procedures are done in a prone fashion. One of the things that is very crucial is positioning patients in as neutral, non-displaced or non-distracted positioning. I typically use a Mayfield head holder. Also, with the use of navigation, it's also advisable to have a translucent Mayfield head holder while patients placed in a prone position. Typically, you would prefer to have either navigation or fluoroscopy. I prefer not to have an over-reliance on or sole dependence on navigation, considering the dangers of it being erroneously inaccurate. The only concern that I have with initial exposure is at the level of a C1, to make sure that you don't have any defects in the bony anatomy. In my practice, I prefer after the initial midline dissection to use a Raytech and a gentle cob to push the tissues gently in a periosteal manner to less than 2.5 centimeters from the midline, which is all more than you need for most people for dissection. Particularly for C1, placement of C1 lateral mass screws, we do think about whether the C2 nerve root will have to be resected. In most cases, this can be preserved, particularly young people, due to the numbing effect in the posterior occipital region. And then a careful dissection to place your instrumentation, which in this case is a 77-year-old male who had a ground level fall and now has a retroflex type 2 odontoid fracture with a significant retrolisthesis of the C1 junction, C1 over C2 on one side versus also distraction injury on the other side. This video shows the placement of the C1 lateral mass screw. This technique is the most challenging since you avoid both the vertebral artery as well as also you needing an assistant to retract the C2 nerve root and also vascular bundle, and carefully using several cottonoids and patties to retract the vascular and neurovascular bundle involving the C2 nerve root and ganglion, and then subsequently using a micro instrument or Penfield 4 your partner can then retract while you place the instrumentation. I prefer that you do both an anatomical check as well as a neuro navigation versus fluoroscopy check. Using fluoroscopy, placement of C1 lateral mass, you're aiming for the anterior tubercle on a 2D view. The preferred screw diameter will be anything above 3.5 to 4.0 or 4.5 for C1 lateral mass, with ideally, if you're preserving the nerve root, a 10 millimeter shank before the tulip of the screw. After placement of C1 lateral mass screw, it's better to place that first before you place your C2, either pedicle or par screw. The In the absence of navigation, the ideal trajectory is and also in the absence of any displacement or rotatory issues, is to find the pedicle of C2, and that bisects the lateral mass of C1, and you can then place your lateral mass screw followed by either the pedicle screw of C2 based on your anatomy and considerations, size of the pedicle, etc., versus also trajectory. A C2 par screw is perfectly uh, easier to achieve without much consequence between ideally 14 for pediatric population, but ideally in adults 16 to 18 millimeter screw will be more than adequate for a C2 par screw. The trajectory of a parallel placement is most optimal. The occipital plate is placed either at the beginning or at the end of your screw placement following lateral mass screws, and it is best to get a fluoroscopy once the plate is on to make sure that you're below the inion, and also if necessary to drill a little bit of a trough to and recess and do actual bending to prevent the plate from protruding or giving you a force vector where it'll be ripped out. It's much better to use blunt coring technique of the skull. Should you have any dural penetration, is to pack it with Surgicel mesh and then chase it with the screw at this point.